Good afternoon, everyone. This is Erin with CMS. It's just now 1 o'clock and we are working on clearing the waiting room. So we'll just give it just a few more minutes before we get started. We do want to give a couple reminders to all the TACs. All voting members must have your camera on while voting. For the recorder purposes and transcript purposes, if we could utilize the raising hand tool so that way we're not talking over top of anyone, that would be great. We're having a hard time sometimes capturing a little bit of the information when multiple people are speaking at once. So I just wanted to make that quick request and friendly reminder, all cameras on while voting, and attempt to use the hand raising or comment, and I will try to grab comments and read them out loud. And we'll give it just a few more minutes as we have several people coming out of the waiting room.
Hello.
Hello, it looks like we've cleared the waiting room if you would like to begin.
Everyone. It's going. I think most of us have probably been here before. Those are new. Jordan Burke. I'm the current interim chair. Been unable to vote on it up to this point, but welcomes the Health Equity Disparity TAC. I'll let Deputy Commissioner Hoffman say hello and greetings to everyone after July 4th.
Yes, happy July 4th. So my name is Leslie Hoffman. I'm the Deputy Commissioner for the Department of Medicaid Services. And I've said before, I proudly serve as one of Medicaid's racial and health equity champions. And I'd like to welcome each and every one of you here today for our July 2023 Health Disparity and Equity Technical Advisory Committee, or our TAC. I will be leaving, Jordan, after I finish the welcome here, but I'm going to leave you in good hands with Danita Coulter and Angie Parker.
Okay. So looks like Katrina might be having some issues hearing something.
Katrina, you might need to log out and log back in. Sometimes that helps.
Do we currently have a quorum, or where are we at?
I believe so. I believe I saw Wanda, Julia, Jordan, Katrina, Patricia, and Roger all log in. Did I miss anyone? So I believe that was 6 of your 10. So you should have a quorum. So you should be able to vote on your past 3 meeting minutes and a new chair.
Excellent. Let's see. So what have we had? We've had May, March, and was it January as well?
Yes, sir.
Okay. I'm gonna be honest, I do not remember January's meeting minutes. But would anyone want a motion to approve the prior 3 meetings minutes?
So moved.
I second.
So, and we also need, I think I might have left it off this time. We actually need to vote on the TAC chair. For the past couple meetings, I've been doing the agendas and things like that. We haven't, had a chance to officially vote on it. I just kind of was put in the role as only available at one of the meetings. We had talked before about trying to rotate chair, which is an idea I'm still, more than open to. It's been, fine, mostly putting together the agendas, and this is just the second one I've had to do. I'm not sure how it works on the end of the tax. Typically, is there if a chair is established, is it like a yearly vote that typically goes through, or how is it normally done if we don't do the like every 3-month thing?
Yes, sir. Typically, it's we tend to run on our state fiscal year, which started on 7/1. So that most tax around the first state fiscal year, whether that's in July, August, or depending on how their meetings land, they tend to vote in their chair yearly. And then I have a couple of tax who have never voted in a new chair because they never change. And so they just kind of skip that process because they know they're going to keep their same,
Okay,
I guess, chain of command, for a better lack of words.
got it. Okay. All right. When it comes to the current setup we have, from the members that are present, would you all like to, continue doing the interim thing where we, shared every 3 months or so to kind of share responsibilities? I think it's nice because making the agendas and trying to make sure we group everyone is not the most desirable, but it is important that someone's pushing to make sure people get here. I think that's important. Would anyone be open to, if the new fiscal year starting now, be willing to nominate or want a nomination or have the time for a nomination over the next few months?
I think I would just suggest that we split, the duties among all the participants, unless you want to continue, Jordan.
Yeah, I mean, I'm happy to, I would gladly help someone or maintain this position for now. But when I think of the health equity disparity TAC, right? I think it's important that we have a lot of different viewpoints and a lot of different opinions and things like that. And the person that is chair, does end up kind of guiding the conversation. And so I don't want to, by default, just have that be my own opinions, which end up being at the forefront. So I'm really trying to find, I think several of you have had a lot more experience than I have in a lot of these areas. You've just been involved in different communities, and your current places of work are in, different areas. I mean, I'm definitely in an area of need for sure as well. But I don't want to just always be the one presenting the ideas.
Hi, Jordan, this is Katrina. I could do it after the first of the year. I really couldn't do it this quarter though, but I'd be
Okay.
willing to do it then.
Okay. That's fine. I can, if we would like to vote on it now, I'll continue to chair through the new year. And then Katrina can, we'll vote at that time, but we'll look forward to Katrina maybe taking over at that point, if that works for everyone.
Great. So I move that Jordan is chair.
I second.
Aye.
And who else do we have? Sorry, I think you said Roger.
Yes,
Katrina, do you mind to turn your camera on while you vote, please?
I'm sorry, I muted myself when I was speaking. I'm Dr. Figueroa. And I have a question. So the recommendation is to rotate shares every 3 months. Is that correct? As an alternative, or?
Yeah, so I think before we had talked about, every 3 meetings.
Okay.
I could be wrong about that, Dr. Richardson, if you recall it differently. I think it was every 3 meetings we would rotate. Doing it this way will get us a little offset because it'll put me at July, September. It'll put me at like 5 meetings in a row. And I'll gladly have someone take the reins after this meeting to get us to when Katrina will take over in the new year. But if you would like to,
Okay.
Dr. Vergara, I'm definitely open to that.
No, and I want to suggest something, recommend a consideration. What if we have co-shares, that we have a chair and a vice chair or co-chair, and they just flip? Because my concern is that by rotating every 3 months, that it could be cumbersome for someone to take a good grasp of the committee and leading the committee and what needs to be discussed. It could lead to fragmentation. And I think that way the chair is not working alone in establishing the agenda or anything like that, but it becomes almost like a training ground, and then it flips a little bit of what the duties are, and also take advantage of the resources that are available to support this committee.
Yeah, no, I totally
Jordan,
agree.
this is Erin, if you don't mind me stepping in just really quick. All the TACs should actually have a co-chair, so that is a wonderful idea. Also, I do want to keep in mind, you do also have to have a quorum every time you want to change your chair. So if you go 3 months without a quorum, you don't have a chair technically. So I think having a co-chair would be a great idea. Also, a lot of TACs, I'm on tons of emails where the chair sends out an email, a couple weeks before, asking for agenda ideas, so you don't feel like you're the only one having to come up with the agenda. The whole TAC is, I know I heard that was a concern of yours. You didn't want to, spearhead and feel like you were taking over. So I just wanted to throw that out there. I know this TAC is also still very new and working through, process and our footing and things. So I did want to throw that out there, that if you wanted to vote on a co-chair, and if you guys are both on vacation in the same week and somebody else can step in and shoot us an agenda to move forward in a meeting, that's always a possibility as well.
Yeah, I think that's a great thought, Dr. Figueroa. Like, absolutely, when you take over and you just kind of are doing it, you have to figure out the whole process again.
Correct.
And if that's happening every 3 meetings, we're never going to get far.
Right.
So would anyone be open for being co-chair? Katrina?
I would be open if we do it that way, because we're not restarting the wheel every time.
Yeah.
And we can provide support to each other. Yeah.
Okay. Okay. So I'm trying to think the best way to go about that then, as far as
And a solution for when Katrina offers to become a chair is that Dr. Figueroa continues to be co-chair through January when Katrina becomes a chair. So she will have the experience and the knowledge of co-chairing with you, Jordan. And then she will continue in the same position with Katrina, unless she wants to chair starting in January, and then Katrina can become the co-chair.
Okay. I think that's
I could do that too. I
Yeah.
could be perfectly happy doing that.
so. Dr.
Yeah.
Figueroa, are you
Yes.
good to
Yes,
begin
I'm good with
co-chairing
that.
along with me?
Mhm.
Right. And then come January, we'll we'll discuss whether Dr. Figueroa, whether you would like to continue, or whether I would like to, or Katrina, who she'll be replacing at that point. But I think that's excellent.
Okay.
Because I do think, although we need stability, having those differing viewpoints will be valuable as well. So,
Yes.
okay. So we vote on, can we vote on that? Can we get a motion for that idea in second and as needed?
I moved to have Dr. Figueroa as a chair for Dr. Burke.
So I think that the motions need to be separate, just for governance. If
Okay.
that we vote on the co-chair, we vote on the vice chair, and we vote on adding Katrina in January, right? Okay, so those are three different things, right?
Okay.
Let's move on Dr. Burke to continue as a chair. I move to that.
I second.
So now
Then-
on to Dr. Figueroa to become a co-chair with Dr. Burke. I move.
I think we have to vote
we
on
need
it,
to
all
vote.
ayes.
Okay,
Yeah, we
let's
need to
move.
vote.
Okay.
Yeah, all the ayes.
Aye.
Okay, then the ayes have it.
Or, yeah.
Go to the next one, the vice
Mhm.
chair.
I move for Dr. Figueroa to become the vice chair.
So moved.
Katrina Bowman, I'll second.
Okay.
All
Do I get
those,
to vote on these as the,
Yes.
okay,
We need to vote in each one of them.
yeah.
all those in favor, say aye.
Aye,
Aye.
Aye.
the ayes have it.
Yeah.
Then the third one will be to add Katrina on
Bowman.
January,
Mhm.
right, January 1st.
The third motion, it's for Ms. Katrina Bowman to become chair or co-chair this coming January 2024. I move to that proposition.
Second,
All those in favor, say aye.
aye,
Aye.
Aye.
okay.
Well, great. See, and that's why I need a co-chair to run these correctly.
Okay.
Great.
Dr. Burke, I'm also learning with you there. So it's not
Yeah.
only you learning.
It's a team effort,
That's
right?
okay, right.
So as we move on, I think you guys had sent the email last week that I'm a lot of these topics are kind of sticking around for us. So as we move into old business and updates, I'm trying to hit on just a couple points of the topics we've had before, grouped a couple topics that have generated a little bit less discussion. We'll bring them up if need be, or if someone has a point on them they want to bring up specifically. We have a couple presentations, I believe, today that we're supposed to get. But I'm trying to get us into a general discussion just to see if we can formulate or come up with new ideas or new questions to ask for Medicaid to get us into more of a thought process of trying to find ways that we can recommend things, because we're getting information in different ways, and we're talking about different topics, and that's all needed to get this information to begin with. But we've been going for not a year now, but we're getting there, and I feel like we really haven't started to focus in on one area that we're really trying to drive home that we need to work at. So I'm just trying to kind of poke and prod and see what we can get. So for old news, we were supposed to have, I believe, a transportation services presentation. Is that right?
That is correct. Good afternoon. I am Angie Parker. I'm the Director of Quality and Population Health. And we do have a transportation presentation for you that our division, and particularly Rachel Rarig, who is our branch manager in research and analytics, put together regarding the transportation access via the MCO program and other various other entities that are available for transportation. We did target one specific area of Kentucky, and Rachel will go through that for you. So I'll turn it over to Rachel.
Great. Thank you, Angie. Good afternoon, everyone. Thank you for allowing us the opportunity to review the very important issue of access to care regarding transportation. As Angie said, my name is Rachel Rarig, and I'm the branch manager of research and analytics within the Division of Quality and Population Health. Okay, so our objective with this review was to combine all current transportation options that are available to Medicaid recipients in one place so that we could gain a more holistic understanding of what access to care is currently available. We'll be reviewing transportation services provided by the state, by MCOs, by community-based organizations, and through public transportation services within a targeted area. And as Angie mentioned, our target area for this is going to be in Eastern Kentucky. So why did we choose to target Eastern Kentucky? Well, we've identified 27 counties whose populations consist of 50% or more being Medicaid members. These counties are highlighted on the Kentucky map below and are predominantly in Eastern Kentucky. This graph shows enrollments in the targeted 4 regions that are based on the identified counties. They're broken down by the enrollment numbers with their MCO. The top MCOs for the targeted area is WellCare, that's shown in green, followed by Aetna, that's shown in red. Similar to our previous Kentucky map that's showing an Eastern Kentucky area with the highest Medicaid population compared to the county population, this map also shows with the dark green areas that the worst health outcomes across the state are also mostly located in Eastern Kentucky. So for these reasons, we're going to take a closer look into what transportation services are available to the Medicaid members in this area and how much utilization of those services are taking place. Here we have the 3 different transportation options that are provided by the state. We have emergency ambulance transportation services, non-emergency ambulance transportation, and non-emergency medical transportation, or NEMT. DMS contracts with the Transportation Cabinet to oversee all Medicaid transportation. The Transportation Cabinet oversees the Human Service Transportation Delivery Program, through which there are 16 regional brokers that can either provide transportation services themselves or subcontract with other transportation providers in a specific area. NEMT riders are permitted the freedom to choose from the providers that are contracted in the area, as long as it's cost effective. And if the rider does not express a preference, the transportation broker will select the provider for the individual. The type of transportation will depend on the accessibility for the client and how appropriate it is for their medical condition and their personal capabilities, while also at the lowest cost. Transportation providers are the only ones that can schedule NEMT services. Their other specific tasks are shown here, and they do quite a bit. The brokers can utilize subcontractors to provide the NEMT rides. And they can do that by taxi, sedan, stretcher vehicle, public bus tickets, public bus passes, accessible vans, and private auto rides. Here we have the details on how Medicaid members can request NEMT services. So this is for you all to have and to review and refer to as needed. Taking a closer look at NEMT, we found that trips are continuing to increase near pre-COVID levels, with approximately 240,837 trips utilized per month by Medicaid members. There's no cap on the number of times a member can schedule a trip, and transportation is available in all 120 counties. A 72-hour notice is required for scheduling, and transportation after hospital discharge can be requested during normal operating hours without notice. All transportation services are ADA compliant. And to speak to Justin's point in the last TAC meeting when we were talking about the proposed regulation changes regarding transportation, this is to remove the current restrictions that members requesting NEMT services have, that they cannot have a vehicle in their household in order to be NEMT eligible, that a vehicle cannot be in the individual's name unless there is a doctor's note stating that they cannot operate the vehicle, or a mechanic's note saying that it is no longer operational, a change to allow parents or guardians of minors to request a 2-week exemption for the child to attend a Medicaid covered service trip with their parent or guardian, as they have the same ownership status as their custodial parent or guardian. Transportation providers will no longer be able to self-refer members. And upon approval of the 1115 waiver, NEMT will also be provided for methadone treatment services. Additional NEMT data include that for fiscal year 2022, there were 2,385,922 trips for Medicaid members provided. Urgent care transportation is available 24/7, including holidays. Transportation to the emergency room is not covered unless there is an order for a direct hospital admit through the emergency room. And for those that need to bring a child or other individual to their appointment, it is up to the transportation provider to provide the transportation without charging them for that child or individual. It depends on the availability of seats, if the seats have been purchased, because vehicles used in the program consist of revenue producing seats for the transportation provider. So it's only up to the transportation provider if they're willing to allow the member to bring someone else without charging them. So if this situation were to arise, the member is put in contact with the specific transportation provider through the transportation broker to work out the logistics of the situation. Medicaid does not have the authority to make that decision. Only the transportation provider specifically does. Most subcontractors do allow members to bring a child in most circumstances.
Rachel, real quick.
Yes.
Do you have a question?
Yeah, this is Katrina. It was back on the recommended changes. I think you said that the providers were no longer going to be able to refer people to transportation. Can you sort of delve into what that means?
Yes, it's the transportation provider. So right now, an MCO can refer a member to the transportation cabinet to get NEMT services, and the transportation provider at that lower subcontractor level, but that can cause a bit of conflict. So the regulation is that that specific subcontractor of the transportation provider, they can no longer self-refer. They're going to make the member go to the broker and go through the appropriate steps like everyone else has to go through. Does that answer your question?
Yeah.
Okay.
I sort of see that from both sides, like how that could create issues both ways. It could make it more difficult for some people, but then I understand you're trying to make sure that there's no that there's fairness in the process. I just think it could potentially lead to delays for some people as well.
Yeah.
Yes.
Oh, go ahead. I'm sorry.
I agree. I could see what we're trying to prevent. My concern is that if we're creating a bigger problem, and if we give clients the choice, but that they take into consideration the referral from the MCO, I think it's giving the power back to a client, but at the same time, not having the client have to navigate all these services and appointments and schedules. That's a barrier in itself.
Yeah, absolutely. And at the end of this presentation, we have Becky and Eddie, I believe, on the call that can talk particularly on any of the transportation questions that you might have in more detail. Okay, so in addition to NEMT services and transportation provided by the state, MCOs can also provide additional assistance for their members through value-added benefits. Value-added benefits are any benefit or service offered by an MCO when that benefit or service is not a covered benefit by the state plan. These benefits are subject to change annually as determined by the MCO. So breaking down with all 6 MCOs, the first MCO of Aetna Better Health of Kentucky, they offer 2 transportation-specific value-added benefits. One called Enhanced Transportation. That's for job interviews or training, going to the grocery store or to community health services. And only 5 members have utilized this service in year 2022 within our identified 27 county regions or counties. So this is, if we recall from the other slide, in the area we're looking at, Aetna is one of those top MCO providers with being able to offer transportation value-added benefits for their members. The second value-added benefit is called Family Transportation. It's for members enrolled in their Maternity Matters program that can receive transportation provided for the family, including having a car seat for the children. There have been 0 members to utilize this service within our identified area in 2022. Both value-added benefits are limited to 10 round-trip rides per year. WellCare does not currently offer any transportation value-added benefits. They do make referrals to Kentucky's NEMT program through their Community Connections helpline. These referrals include general transportation support and medical transportation support. And WellCare is the other top MCO provider within our identified area in the 27 counties. 52 members have utilized the general transportation service referral in 2022 in our targeted area. And 83 members have utilized the medical transportation service in 2022 in our targeted area. The highest number of referrals that we're seeing from WellCare in 2022 is in Floyd and Perry County. United Healthcare does not currently offer any transportation value-added benefits. They do offer a non-emergency stretcher transportation that's not provided through NEMT services, through transportation brokers. They've had 0 members utilize this in our targeted area in 2022. Anthem offers one transportation value-added benefit in the form of a $50 gas card, bus pass, or Uber card. It's for all members who are over age 18 that have completed a health risk assessment within the first 6 months and a wellness check within 12 months. The member can obtain this benefit on a quarterly basis with a max allowance of $200 per member. In 2022, we've had 658 members, Medicaid members, utilize this value-added benefit within our targeted area. The top counties were Whitley, Knox, and McCreary. And just of note, the gas card, bus pass, or Uber card amount has increased to $100 since then for 2023 on a biannual basis. Passport by Molina offers 2 transportation value-added benefits. One is for the $50 gas card, bus pass, or Uber card, but the eligibility requirements are a bit different. These are for members already engaged in supportive services through case management that are identified as having a higher level of need. 40 members have utilized the gas card, bus pass, or Uber card value-added benefit in 2022, with the top counties being Whitley, Knox, and Johnson. The second value-added benefit that Passport offers is a reimbursement program for lodging, meals, and transportation to medical appointments. This is also dependent, again, on enrollment and case management and other stipulated limitations. 19 members utilized this reimbursement value-added benefit in 2022, with the top counties being Bell, Magoffin, and again, Whitley County. Humana Healthy Horizons does not currently offer any transportation value-added benefits, but the care managers do make referrals to Kentucky's NEMT program for their members, with 36 referrals being made in 2022 within our targeted area. The highest number of referrals were in Lawrence County, and Humana also has 2 current pilot programs for transportation that include the maternity transportation in Louisville and a bus pass pilot program to members receiving care at 7 county services. So here we have the community-based organizations, which also can help with transportation, of community action agencies and what transportation services they provide. So here we have the mobility service, door-to-door service with transportation, and curb-to-curb service. And this is for employment, going to medical appointments, going to the pharmacy, education, or just going to see a friend. So trips need to be scheduled for them for 24 hours in advance. And that last point is the number and website that individuals can go to for community action agencies in their area to get more information on transportation services and for scheduling. Public transportation, of course, is available for all individuals. In the targeted counties, the transportation providers that we have it listed here as a reference. So we've discussed the issue and the data. To summarize, the transportation assistance that we have is available by the state, by MCOs, community-based organizations, and through public transportation, all of which are ADA compliant. Additional transportation support is needed in the Eastern Kentucky area, where the county consists of 50% or more being Medicaid recipients. And the highest utilization of transportation services within these counties is Whitley, Floyd, Knox, and Bell counties. NEMT is the largest used transportation service for Medicaid members. This here is also a clickable link that has a lot of really good detailed information on the NEMT process and specific information that's good to know. The top value-added benefit for transportation that was used by members in 2022 was the $50 gas card, bus pass, or Uber card that had limited eligibility requirements. So the great news is that we have the opportunity to increase access to transportation for our members. We can continue to evaluate ways to improve transportation and access to care for underserved communities. MCOs can evaluate adding value-added benefits specific to transportation. Member and provider education can be provided on how to connect with local community-based organizations and public transportation options if the member does not qualify for NEMT services. We can improve communications around the NEMT process for members to make that easier. And we're planning on updating the NEMT regulations to provide coverage for more individuals. So located at the end of the slide deck, there is a very detailed appendices here with a lot of good detailed information for some of the items that were discussed at a higher level through the presentation. So this is for you to have and refer to as needed and to keep as a reference. This is the end of the presentation, so I'll be happy to take any questions or entertain any comments that you all might have.
This is good information to begin with. Thank you for providing this. And my question is, I know that the focus have been in areas, you have targeted areas where transportation is a bigger barrier than in other counties. What are the plans to include other counties in this program?
Great question. As we like to say, you can't boil the ocean. It is a statewide problem.
Yeah, it is.
Right. So this is just our first view of the most needy portion of the state. And of course, we're going to spread out from there into different areas, but this is the one of primary concern that we're going to start with.
And a lot of what Rachel discussed is offered across the state. So
Yeah,
you know, the value added benefits, the NEMT services, the CBOs. So those are all available. It's a matter of looking at what's the utilization of those. And we can probably go look at statewide.
Right.
Yeah,
these are value added benefits from MCOs. Are we planning to include this whenever we are negotiating the Medicaid contract with MCOs? Because transportation is one of the biggest barriers to treatment, and no MCOs are going bankrupt because they are providing additional benefit to their patients. And honestly, this should not be something that they do out of the goodness of their heart, but rather like an expectation in how they are helping the state, the Commonwealth, to improve the health, access to health care. And so I think it's more of a comment that, again, this is great information, and it could be used to evaluate MCOs when we are reviewing their contract.
All MCOs offer a value-added benefits, not just transportation. They have more than one just thing. They have different. And I'm not familiar. I don't know if you're familiar with those value-added benefits, and we can certainly provide this committee with that information on the different value-added benefits that they do provide.
That would be great.
You know, there were some that don't offer the transportation, but they may offer something differently.
Right.
There's also a question in the comments asking if the amended regulation has been filed yet, and if not, do we know when? Jonathan, are you on?
I am on. The amended regulation has not yet been filed. We are hopeful it will be filed in a couple of months.
I mean, some of these value added benefits certainly seem, more enticing than other. I mean, we've seen in the MIC, data that anytime there's like a gift card or something like that, people definitely go after that more because they're actually able to use it, to get food or transportation or something like directly in their home that they can control. Like the value added benefit that had 0 people accessing it, is that an issue of the MCO not telling people about it, or is it actually a benefit that if it's too complex to get to or access, or if it's not being used, then it's not really.
Yeah.
Which I think that's where we come with when we're looking at this and at all the data and the opportunities that we saw within this presentation.
Yeah.
Is that members and providers need to be educated more on what is available.
Yeah, for sure.
I mean, even when you look at those who offer value added benefit, and I don't have the specific, but they are very low numbers, even for those who do offer those benefits.
Oh yeah. Yeah, I mean, the highest one I think was what, like 684 or something like that, and the
Yeah.
Anthem one. I mean, it's still
Right.
incredibly low.
Mhm.
And for some of these MCOs, the requirement has to be, is that the member has to be on case management. So that's another thing, because to get a case manager with an MCO is not an easy thing. And so if you have to be under somebody trying to help you to get another service, it's just an extra step that has to be taken in order to get access to the service. So,
And one thing we don't know yet either, because it's like, whenever you look at data, it always brings up, where we need to dig a little bit further. So of those who utilize the service, how did that help with their overall health? And what were the outcomes of that? So with the low numbers, it's very, you can look at those the persons or the members who utilize this service and what they utilized it for. Was it a doctor's visit? Was it, what specifically it was? And so that's something else to kind of drill down on as to those who did use the service, what was the outcome and what they used it for. And I see Dr. Richardson, you had your hand up.
Nope.
I was going to say what Dr. Bautista said about having which of these require you to be in case management to access. That would be an important question because that takes out most of the population. When you're talking about, which I guess you all could research and kind of tag which ones were just care management based versus open to the whole population. I know you mentioned talking about member education, but definitely provider education when you start to develop materials and making sure that we are aware. But I think to me, the bigger issue is, we've had transportation problems before we had MCOs. So, and we know that value added benefits, overall, the uptake on any value added benefit is so low. Certainly value added benefits may not be the best tool right now to improve our access to transportation because it's a tool we have that's not working in many different arenas. And so I think the underlying issue is there's a historical lack of confidence in the transportation system. We have heard over and over and over, it doesn't come, or it comes too late, or they don't ever call us. And so I think that is the underlying issue from my patient's perspective is people don't trust it enough to even try to use it. Again, because they've had such bad experiences for years and years and years. So why would they think it's any different now? And so it's like a whole rebranding for providers, for patients, for the MCOs. So how do we get to the bottom of this lack of historical lack of trust because of historical challenges with the program? To me is the issue, because we can access all of the transportation without any value added benefits. So we could, you know, so anyway, so I think there's a historical lack of confidence, lack of trust in the system. So I just wanted to ask for thoughts on how you might be, ideas about addressing that.
Well, the first thing that came to my mind was a survey of those who use it, who are using it. But I'm also, you know, I'm going to turn this over to the committee. What are your thoughts on the best or how to address that?
I mean, is there any way to, I mean, that question in of itself, possibly a survey, but if you had the people that, if you only asked the people that used it, that might, you know, start off with people that were more willing or more trusting to use it to begin with versus the people that never did actually use it if they didn't have trust in it to begin with. So if you just did, I guess, of potential, you know, people that are covered by the MCOs, you just asked anyone and not just necessarily people that did access it, you know.
Jordan, has that been your experience too with your families? Sort of like, well, we tried it once and it didn't work, or what's been your experience?
Yeah, sometimes I've heard, you know, different issues. Sometimes it's, you know, whether they were late or they did come and they just said, you know, the patient told them they couldn't go that day. So I've definitely seen it on both sides. What I'm trying to think is there a way to compare? I'm sure there is, like the different MCOs and how they approach their patients as far as notifying them about how the transportation services work, going through the system of actually coordinating that for them, and seeing the difference in how often actually patients that need this type of transportation, like the patients that are in Eastern Kentucky, is there a difference in actual outcomes as far as how often the patients under this MCO actually go to their appointments when they're part of the group that needs to use these transportation services? And if this group goes 40% of the time and this group goes 15% of the time, what is the difference? Like, what are they doing different? 40% obviously isn't ideal, but it's a huge gap if there was something like that underlying. You know, if you look at everyone goes 15% of the time, that's harder to address, but
that would be a good first step, I think. And then also it's important to keep in mind when comparing all 6 MCOs and the transportation value added benefits, the most successful usage in 2022 was Anthem. And that's in our 27 identified areas, over 658 members. But we got to remember, Anthem is not even the top MCO in that area. So
exactly.
Right. So if the top MCOs offered what's already working for that area, that might be something that an avenue they can look down to increase the utilization as well.
There's a question in the comments from Katrina. She asked, who determines what types of trips are approved?
For NEMT services, that would be the transportation broker. So the transportation broker is the one that makes sure that that person has Medicaid eligibility, that they're going to a Medicaid approved service. So they'll go through and make sure that they have everything they need in order for that person to receive NEMT services.
Thank you. There's also a comment from Tabitha with Anthem stating that they do offer new member orientation to educate on all of their services and value added benefits. This has helped them to learn what's available. We have also designed our value added benefits to have a great annual visit doing HRA so we can further encourage them to participate in their healthcare.
And I think Tabitha is addressing something that is very important. Many members or many Medicaid members don't know of the services available, don't have any idea of what an MCO is offering. They don't even know that they can request case management. So I think what she is highlighting is just to make the knowledge of we have this service and it's available. It's the first step and doing whatever the MCO is doing.
I guess if there's something I could ask happen for our next meeting, would we be able to get that data as far as the difference in, I guess, both utilization and how often it's actually successful? Like if they're trying to use one of these tools for transportation, how often does it actually work or not work, or what? I'm not sure the exact question asked there, but I'm sure someone understands what I mean.
Now, if it's specific to NEMT, we can get information from the Office of Transportation specifically on how many individuals contact the office to request services versus how many are eligible and actually took those trips. So we can collect that data if that's something that you all would like.
Yeah,
And I think to that point as well, how many of them who requested it but ended up not going? Because we also have we also have a project, and I don't know how many of you all are aware of our missed appointment that you could put in the provider portal or the member portal. And so we're tracking that as well per MCO. And when those persons missed an appointment, that information is shared with the MCO so they can do outreach.
Mhm.
So it's a challenging,
yeah.
as most of these
There's
social
this-
determinants of health with our Medicaid population, very challenging on how to to get people to utilize what's there,
Right.
regardless of, if there is a $50 gift card associated with it to go to their appointments. And to have the patient buy-in. I understand, they have to be in case management for us, for a few MCOs in order to get that. As far as educating members, they all get member handbooks, they all get newsletters, and not with that, with information, but just like, okay, you get something in the mail, do you read it? Do you throw it away? That kind of information. So it's the responsibilities of the person, the Medicaid member, as well as the MCOs and providers. It takes a village to make sure that, everybody's getting the information and being provided all of the services that they are eligible to receive.
The question in
Do you
chat-
have the list of what's approved for the Medicaid trips? I ask that question because I think a lot of times people are multifaceted and they have several different things going on. And I saw someone mentioned in the comments about social determinants of health. What is considered an approved trip, because it could be difficult just to only go to the doctor when you need to go to the doctor, and you need to go to the grocery store, and you need to do, various things that all tie back to your health. So I'm just wondering what is approved on that list, and is there a better way to package that service?
Is that for NEMT, or are you wanting to know for the MCO value added benefits?
Just for what is the actual approved list?
Okay, we can certainly get that to you regarding the NEMT services and specifics. It has to be Medicaid approved service, things like that. And Becky and Eddie, that's on the phone, that knows a bit more about transportation, consider things of that nature. Do you all
I
have
think
any?
it said Medicaid approved, like that's what I'm asking. What are
Yes.
Medicaid approved trips? And and I guess my real question is, do they take into account those social determinants of health issues on that list?
Hey, this is Becky Downey. I know that the approved trips, like Rachel had said, they do go through the transportation cabinet. They're the ones that all of that goes through for approval. The one problem that we run into is there are so many trips scheduled every day, for doesn't matter what county it is. And it's a lot of times it's very hard to schedule one person for 3 or 4 different stops. You know what I mean? Like, we look at
Mhm.
the doctor part of it, of course, because that is most important. Um, but depending on, the amount of people that are on the vehicle, yes, sometimes I know that they have worked things in where they've taken somebody to the pharmacy too, because they had enough time to do it. But unfortunately, it does come down to time restraints. And of course, how many are on the vehicle, that are going to different places. So that's another one of those things that we have to work on, if we can. It's just, it doesn't seem like we have enough vehicles for everybody.
And maybe that's just, in particular areas, because some of these are very, very underutilized. So, yeah, I could see that in some of the play areas where there's more utilization, but in the areas where there's very few people even taking advantage of that, I couldn't necessarily see where that would be the case. But I mean, I get your point with that.
And no, you are right. I mean, if, they utilize it and there's, like I said, if there's not but, 1 or 2 people on the vehicle, I presume from what I've been told that they are able to work in those other trips. Um, it's just a matter of each of those counties that are lacking, just reaching, those people reaching out to see what can be done to help. I mean, that's kind of what it comes down to.
Right, and that's at the discretion of the individual transportation provider.
Yes.
So just like with having another individual go on the trip with them. So if a situation like that were to occur, or if they say later on, hey, I also need to do this or go here, is this possible? Then the transportation broker would put them in contact with that provider. And so them two could have direct communication on figuring out those differences and if that's feasible for that trip or not.
Yes.
Okay. Any other questions for the transportation access portion? Really attacked in chat.
I can just say it real quick. I know when we talked about this a few meetings ago, we're like, well, how do we capture the people's complaints? And I think somebody checked with Department of Transportation, but there weren't, because that's where maybe the complaints are going, but there weren't any complaints. So if people had a way to express their concerns when they don't show up, or if there's problems, that also could be a good data source.
Absolutely. And if you all need anything else from our end on transportation, we're very happy to do the research and dig a little and provide all the information in one place, the way we did with this presentation. So that way everyone's on the same page on what's out there, what we can work on, what can be improved, and then we can go from there.
Yeah, thank you so much.
Thank you all.
Okay. We had talked a couple of times about if there's any data showing out of state specialty like utilization, like how many people are actually going out of state, how much. We said it was mostly probably single case like agreements. Did we ever get like a total number or any larger data on that?
I'm not sure who it was that was going to reach out for that, but I can certainly reach out to see the number of utilization outside of the state and get back to you on that.
Okay.
Aaron, can we get some numbers from the MCOs?
Yes, I was trying to find my unmute button. We have some information I've been collecting from the MCOs for another TAC. I believe the deadline for that was the 10th of July. So once I have them all, I will get them out to this TAC as well.
Okay, awesome. Thank
Perfect.
you. Dr. Richardson, for the next one, did you have a chance to talk to any of the providers? You said you had mentioned going around Louisville to show like what current or the most up-to-date immunization fees were being offered versus what they
I
actually thought
think I
about
was-
that.
Yeah, I felt like I was still waiting for the final list to be updated, so I have not
Okay,
get the fees, but because I
Okay.
knew that oh shoot, what is her name of immunizations? I thought she was still working on some of the final fees, so I do still have that, and I will follow up with her to make sure we get the final list.
okay. Does anyone here currently know if we have the most updated list or how long that's going to be till that's as up to date as it can currently be? I know that Justin had said, it's continuously ongoing and things like that. Can anyone answer that one? If Julie, if you have the contact of whoever was working on it, you can just follow up with that.
Yep, I will.
All right. Next, I listed a couple of the topics, like I had said. If anyone has anything specifically within this group of topics, telehealth, juvenile health, community health workers, interpreter coverage. Actually, I switched over. Immigrant health worker, Dr. Figueroa. That was I think something we said that you had mentioned before. We had not got to discuss it at the last meeting, but is that something that you had worked on before? Dr. Figueroa?
No.
Okay.
I have not.
Okay. So I guess we were trying to figure out where that had come up. It had been a prior topic back when Dr. Richardson had been in chair, and so it's just kind of been pulled forward. But if there's nothing on that one at the moment.
Mhm.
I think that was the one that Dr. Marta had chaired, and we were trying to track down the content from those meetings, but we think it's not available.
Okay.
Right.
But that it's important work to find ways to connect with the immigrant community. So maybe we just start fresh with how we effectively do that.
Yeah. I mean, we could discuss that now again.
Mhm.
In your areas that are more urban, certainly the populations that you deal with, you probably come into these issues more than I do. So I guess what types of things have you seen from that perspective? Anyone?
But-
I think we're all silent because it's such a big question.
Yeah.
We're
It
like,
is.
what do I see? Where do we even start?
You're right.
Okay. Well,
What do you think that the main, based on what you see, what strategies do you think would be more impactful?
What's that to me?
Yeah.
Oh, I think first and foremost is maintaining listening and having a really clear communication channel so that we can hear what the issues are continuously. I think all of us could sit around and identify the top 20 pretty easily, but finding a way to maintain the voice of the immigrant community effectively probably is where we need to strategize. That's just my thoughts.
Yeah, I agree with that too. I think, working with that particular population, you have to build trust, and it has to come from a trusted source, and it's not something that sort of an outside group can go in and really get the information that's needed. So it's figuring out who the community trusts and then trying to work with them to get that information to make the access, to make the services more available. And for the system for the healthcare system to be willing to maybe do some things a little bit differently. When you think about the way we operate now. You go in and you fill out mountains of paperwork that just doesn't work for most immigrant populations of people. So I think once we do gather information, then people have to be willing to think about interacting with those communities differently.
And that's a great point. I think that developing that trust is very important. And nowadays, I think people are more afraid to identify their needs because they don't want to be perceived as takers, and also because of the current climate. And so I think identifying groups in the community that they trust and involving them will be important.
This may not,
But that's going to be hard. It's hard to do nowadays.
it may hold less true. I feel like a lot of the situations, when I worked in Florida, or like, rarely, but occasionally here, when I deal with, that population, what I find is that it's often an emergency. When I do see the patient come in, it's something fairly bad, and often they're uninsured. We have to get the process started for insurance. Sometimes again, they used to be covered, now they've run out because they haven't used it in some time. What's the process for patients within this population that we identify for them to maintain I guess insurance? Like, do the insurance companies reach out for renewal? Like, what's the process for, I don't know, if that population is less likely to renew? Because I feel like, again, this may hold less true than when you guys, but I definitely feel like that's been my experience for a lot of patients, especially the ones I've seen in the hospital, that do come in with more urgent needs. It's that, we often are starting the entire process of getting them insured while we're doing the healthcare. And I know it's like retroactive and they get coverage and things, that's not the problem. The problem is 2 years later when it happens again and the process has to go, all the way back through.
I think, and I can only speak for the community that La Casita Center works with, is that we are trying to encourage people to trust into the health organizations that have been our partners and that offer health service for this community, like family health centers or family community clinic, because for them to go to a place where there is lack of interpretation or the need of certain literacy level, it's a double barrier. So, and I agree with you, they will go to the doctor in case of an emergency. What we're trying to do is just instill in our population the importance of going to the doctor at least once without being sick, to establish what is normal for them or to identify it early before any troubles if something is happening. And that's what we're trying to do right now. But then it's this humongous, it's really big, and it's gonna take a whole lot of work and teamwork to be able to make this better. And the trouble with health insurance, if you're a migrant and you don't have a social security number, you won't be eligible to get health insurance unless it's an emergency or there is a presumption of eligibility if there is a pregnancy involved. And these are temporary coverage, like for 90 days, but nothing else. So our community and the community that we work with, it relates on having a sliding scale for disease treatment or health prevention in case of pediatrics for vaccinations and everything else.
Can I just add one more thing, Jordan? I think, when you all were talking, you have to think about what's within our control, like the people on this call, first and foremost. And
Mhm.
I'll tell you a story. So I had a newborn today. The family has they have a large family. This is their newest baby. And I came in, I did my thing and used the Somali interpreter. And I said, at the end, do you have any other questions? They're like, can we transfer our whole family here? Kids had been established somewhere else. They don't use interpreters. And this is over and over we hear at other primary care offices, other subspecialty offices. And I know I sound like a broken record because I keep bringing this up, I think, every meeting. The MCOs say that they cover interpreters, but the barriers to access those interpreters are too high. Bottom line, is the barriers are too high. We need a 1-800 number. It's fine if we have 6 1-800 numbers. Better to have one 1-800 number for all of Medicaid.
Mhm.
But that needs to be, I don't even need to be able to think about, oh gosh, okay, well, I need to call this number and then I have to go through a phone tree and then I have to push 7 for this. And the phone, there's just excessive phone trees. And so we need to really nail down every single MCO, no barrier, no phone tree. You dial directly in, push your number for your language and get an interpreter. It needs to be less than 20 seconds. And that is something that is within our control and would have a huge impact. Like, why does that family have to completely switch where their children are established to our office just for interpreters? Like we're busy. We don't need more patients. So, but now because we use interpreters, we're going to get that whole family transferring to us. And we hear this every day.
Right.
It's not,
Mhm.
this isn't a one-off kind of thing. So if
Good
we
point.
could do anything as advocates, having a 0 barrier access for interpreters for medical visits.
That's a good point.
I second that proposition.
Yeah.
Anybody from Medicaid have any thoughts on that? Because I've spoken with every single MCO multiple times, and there are ways to kind of access for most of them, but it's just the barrier. It's just, if it's going to take me 3 minutes to access the interpreter, I'm going to use our paid service, which is just adds, we're paying for it and not
Mhm.
being reimbursed.
Yeah. I'm trying to think of how we would go about.
All they
I
need to
think-
do is change their phone trees and just give us the direct number directly to their interpreter services. Right now, we can get to their interpreter services, but there's just like a giant phone tree to get there. So there are barriers. And it's too, the nephrologist isn't going to do it. The cardiologist isn't going to do it. They're just going to,
Yeah.
if it's too hard.
Okay. So oftentimes, again, I don't have to use this service as much in Kentucky, so I haven't had personal experience with it. When you do you have to look up like that patient's insurance, look up their interpreter, call a number, and then you get put into the phone tree, and that you're waiting on that part? Or
I mean, it's a little different for all the MCOs, but basically you kind of call customer service. So you're in the customer service phone tree. And first you have to listen to all the announcements that are on the customer service line. It's just that, it's just like any cumbersome phone tree, like you're calling anybody.
Mhm.
So
Mhm.
we just need those direct lines. We don't need to have to call customer
Mhm.
service. We just need to know, this is the phone number directly to access WellCare's interpreters, for example.
Mhm.
Just 1-800, press 1 for Spanish, press 1, I'm done.
Mhm.
I don't know, trying to think if there's a way that, on the patient side as well, if, I don't know if, did the MCOs, they probably all have like apps or something like that. I mean, do they have, a button that says request interpreter or something like?
Can we ask the MCOs to come to this meeting and give a presentation about and then we can make those recommendations to them directly.
Well, I
Yeah.
think they're all on the call, and I'll just say I've spoken with all of them multiple times.
Specifically,
and everybody has an interpreter. It's that we just need somebody in leadership at the MCOs to release that number. That's the bottom
Mhm.
line. We just need somebody to
Okay.
say releasing that number.
This is the
I'm
number.
sure they're afraid it'll be, I don't know, maybe be overused or that it'll get into the wrong hands. I don't know why that gate is there, but it's a gate that it's not good for patient care.
We can request that information from the MCO.
Mhm.
And if
Okay.
any of the MCO partners are on the call and would like to speak on this issue currently, if not, I
And-
can send a request out for that after the meeting.
Specifically, what we'd like to see how the current MCO services set up, how interpreter services are accessed. Is that specifically what we're wanting from them?
No, I think what we want is the number.
Mhm.
Because it's all online, like how to access it. It's all on there. It's just the
Mhm.
barriers are too high. So I think we know how to access it. It's just too high a barrier. So we just want the number.
A simplified
I'm
way,
sorry.
a simplified way to get to an interpreter without going through all those steps, just one straight shot for all of it.
I'm so sorry, Dr. Patty. This is Darren with WellCare. We do publish our number as well as have an online form. And all that we request is a minimum of 5 days to make that available. Members can make that request either again through online or customer service, or the providers can do that as well. And that service is readily accessible for all of our members.
So you said there's a 5-day lead time, but what if we see it?
We do request a 5-day lead time.
Yeah, that doesn't work in primary care.
It
It might work in
doesn't.
other
Yeah.
settings, but it doesn't work in primary care.
Yeah.
Well, what's the issue when you have an appointment for that? I'm sure there's special occasions we can try and make arrangements, but for the majority of appointments, there's a 5-day wait time, when you have an appointment.
Not maybe, not in primary care, but I understand it might work in other areas. Now, if I have a newborn, they don't know, we get 1 to 2 day notice. If you have a sick child, same day notice. So yeah, 5 days doesn't work in primary care.
Okay, that's a fair point. I will
Yeah.
check back with our care managers and see what can be done for that, whether if nothing else, we can do that telephonically and have someone available that way.
Yeah, telephone is all we need. We just want the direct line to access an interpreter, like within 20 seconds.
Okay, let me see, that might be in place. I honestly just can't speak to that. I can speak to all other, scheduled appointments, but that's a fair point. And let me see what that is and share back with the group on that.
Yeah, Dr. Richardson, I mean,
Thank you.
for sure. The vast majority of my patients are, I know when they get here, there's no lead time. So, yeah, it definitely has to be more accessible in your type of situation. Okay.
Is there a way that we can get the data about the utilization of interpreter services by each one of the MCOs? Because it might be that same thing like with the value added benefits, that the benefits is out there, but in some instances, no one accessed some of these benefits. And then with language interpretation, do we have, are we serving that population, or the utilization is as we expected that to be, or is lower? It's going back to the question of the concern of accessibility and how cumbersome sometimes the system can be, especially for primary care, right? But taking a look at the utilization and reviewing that, I think that's a good point. It's a starting point.
Yeah, I mean, the fact that like they're in the hospital setting, again, you have interpreter services that are available to
Right.
the hospital, but like you said, for the MCOs, if they're covering interpreter services, then it has to be faster than 5 days. Like,
Right.
there just has to be more. I know the best way to get that data out, but you would imagine that part of it, the services aren't being offered because the need isn't understood, like there's
Right.
definitely a need for that type of thing. But maybe we just haven't asked the right question to figure out, how lacking we are for it. I don't know the best way to get that, even if you looked at like primary language or something like that reported, you do have a lot of people that are bilingual and would speak more than, they wouldn't necessarily need an interpreter, but yeah.
This is Ashley Hobbs with UHC. So speaking with looking at Spanish speaking members, we have some call center reps who are bilingual. If it's a language outside of that, we have our language line, which to your point, Dr. Richardson, it's not an immediate you call, push a number, it takes you right there. So there is a little bit of a phone prompt, which I will take back to our call center team to see, if anything could be changed with that. But we do have the language line, so the member would be able to have access to an interpreter right then. And then as far as scheduling like an on-site interpreter, I think that's where like the 3 to 5 day turnaround time comes in. But we all should be able to immediate interpreter languages over the phone, if that's helpful.
Jordan, this is Erin with DMS. Kelly also just forwarded me some information from another TAC in March where all of the MCOs provided us their interpretation services. So I will attach that to the email that I send you guys following this meeting. So I won't have to request that information from the MCOs.
Okay.
But I can request utilization data if you'd like. And then if there's something else you'd like to see about the interpretation services, just shoot me an email and we can go back to the MCOs. But we can see if maybe this information has what you're looking for already.
I've reviewed all of the information from the MCOs, and the problem is their phone numbers, but the barrier level is high. So you call that number and it's a a long phone tree. And so what I think the ask to them is, can you provide the direct number to your interpretive services to avoid the phone tree? That's the ask.
Okay.
Thank you.
Okay. Anything else regarding those areas?
No.
Okay. Anything else under the prior topics as well? I mean, interpreter coverage was essentially one of the topics listed there, but we touched on it. I believe we were supposed to have a gear tool presentation a couple meetings ago, but it keeps getting pushed if that's available today. I believe it was going to be Leanne Fitzpatrick that was going to do it.
I don't
No.
see Leanne on here.
Okay.
Let us look into that.
Okay. Have there been any MIC updates since our last meeting? I think what they were supposed to have narrowed it down quite drastically from the last time. I think the number of different
We're trying, but I'll let Danita address that.
Believe the gear tool presentation was done in the last meeting, but I did have to miss it. And I do apologize. I have a 4-week-old screaming in the background. But I believe Danita's here to give a brief, quick update.
For the gear tool last time, they said that there was going to be some more updates added to it. And so they didn't want to present it twice. That's why it didn't end up being done at the last meeting.
Okay, my apologies.
Yep.
Correct. Leanne was going to do the gear tool and I'm going to provide the update for the MIC. We did have those innovation showcases. So just as a reminder, just to go on record, the RFI was opened on March the 14th, closed April the 11th. we had 104 innovators that responded. And again, those 6 areas of focus were the food and nutrition security, housing affordability and quality, the transportation services, economic stability through education and employment, navigation and coordination of care, resources and services, and then the infrastructure and data tools for providers, plans, and SDOHs. So as we reviewed those applications, we narrowed those down. For Kentucky specific, because again, there are, we started out with 4 states, Iowa, Kentucky, Nevada, and New York, narrowed those down. We had 1 state that dropped out. So Iowa, Kentucky, and New York remain. But for Kentucky, the specific interest was around infrastructure and data tools and the SDOH. So we were able to put those into 2 showcases. For the infrastructure and data tools, we looked at 5 specific innovators. And for the SDOH showcase, we looked at transportation and housing specifically, and there were 8 innovators. We had a follow-up meeting that was specific for the state after the MCOs reviewed those innovators, had their recommendations or either scored those innovators. So there was high interest in a statewide approach with transportation and housing. So we're going to do a follow-up meeting. We want to take a deeper dive in what those innovators are offering before we have further conversations, what barriers they might have, what the statewide approach might mean for us. So our team has a meeting scheduled with them next week. So we will have more conversations before we meet with them, but the MCOs will again meet. I don't know if they're going to meet with them individually at this point or if they will have a group meeting. So after we meet next week with the mixed strategists, we'll determine that further. But they have very specific requests. And so that statewide approach is what they're looking at. And again, that transportation is the highest interest. So we'll be looking at that further. And then just additional activities from the MIC is that, you know, from that series of those 6 TA calls, we did have our second call where we were able to identify with the MIC what our goals and objectives are specifically, and some of those potential technical assistance that we will be looking for from the MIC strategists. The MCOs, they have all submitted their SDO action plan worksheets to the MIC, so they know, the strategists know what the MCOs are currently doing, you know, in the area of SDOH and some of their potential planned activities that they hope to accomplish with the MIC. And each of our MCOs have also provided equity tools. So they will be using those equity tools for any future strategies that they pursue, and they'll use those equity tools to review their current strategies. So that is the current update on the MIC, if anyone has any questions.
Thank you. And so did that, I heard Danita say that Liam was going to present the GARE tool, but wait, said she's not here, correct?
Correct, she's not here.
Okay, that's fine. I have moved the window. Okay. For health disparities reports, we had talked a couple times. We had asked if the MCOs or Medicaid had any reports kind of highlighting the health disparities to show us and kind of get us to maybe think of some questions or ideas.
We are still looking on how best to develop those health disparity reports, and part of that will be ongoing. You know, as we had talked previously, this is a new division and we're working with each MCO Health Equity team. And I would say there will be more to follow.
Wondering if even just the DPH reports, like the diabetes or the asthma, they seem to always have disparity information within theirs. I don't know if that would be applicable or worth sharing.
Well, I mean, the Department for Public Health, we would have to, if it's on their website, obviously, we could bring that up. But at what we have specifically for Medicaid, we are revamping some of our reports to make sure that we are including that information. It's a challenge because not everybody reports that information. So we are also actually working on a survey just that will survey around 500 people. And Rachel or Danita, you can correct me on this, to see what barriers they have in reporting this information. So it will give us a better idea on how better to ask the information as well.
Right. So for example, right now, when an individual contacts DCBS to apply over the phone for Medicaid, it is a very straightforward question. What is your race? What is your ethnicity? And we do not get a lot of data on that, and that we know that that's an issue. So unknown is the third highest selected option. So currently what we're working on is, given the climate and the fact that someone could be a bit irritated, waiting on the phone for quite a while, we need to be delicate in how we approach certain questions in order to get more results. So we're working on a survey right now that's going to go out to the general public to see how should we word this best to be respectful, to be able to get the most from the responses, so we can actually have that data, because not having it is a big barrier, and our data is not clean and clear the way that we want it to be. So that's one big change that we're working on to make sure that we get the information with disparities and different information that we need for our initiatives.
Okay. And then we've had Minority Health Report on here for a few meetings as well. I don't see Vivian on today, but I kept the link at the bottom. It's 60, almost 70 pages if you want to review it. I mean, I think that highlights a couple things in and of itself.
But just an FYI, Vivian is no longer with Public Health. So
okay.
I'm not sure who's taken her role over.
Okay. So yeah, as I said, it's listed at the bottom to review. So yeah, this was kind of my goal, was to at least to get into general discussion. We've not really been able to get to this point to just kind of talk openly the last several meetings. So are there other areas that anyone has been thinking about that we haven't been covering as far as disparities in equity? We've talked a lot about transport. I mean, we know that's a big one. The other things that we've been looking at the MIC, what they're trying to target and things, looking at what people actually say they want, vouchers for food, things like that. Again, I'm just trying to figure out what way we can ask questions and give recommendations that's actually beneficial.
Mm-hmm.
One thing that I'm hearing a lot from, and it's not anything that we've really covered today, but just when people are accessing their health care, the disparity between how people are treated, with their treatment and with their diagnoses. And I'm not really sure, I'm not a physician, so I don't know, but I just continue to hear this more and more about people, particularly people of color, that are just giving multiple referrals and they're going to several different doctors before they're being correctly diagnosed. And so I don't know really how to get at that, or if that's even something for this group, but it's just a big concern that continues to sort of bubble up to me in at my desk, in my position, and just something that I'm thinking about a lot. It's just this disparity in treatment, particularly with women of color.
Yeah, no, I mean, that's an important one. I mean, I think healthcare in general is getting so much more subspecialized, right? A lot of the things that we used to kind of address, certain primary care physicians, could begin to address, we have far better treatments for now that we don't necessarily always do ourselves and the subspecialists do, but being able to arrange that relationship better, right? Like for the patients that I have go to Lexington, the transportation issue is huge, and it's not because it's because I don't have that subspecialty access where I am. If I did, that barrier would be a lot easier to overcome for those people. I would still have trouble, like just like you guys do in cities, getting patients to their appointments that are just across town. It's still hard. There's certainly that does affect it a little bit, but that's definitely a difficult one, and it does disproportionately affect, as you said, people of color differently. And there's, I can't imagine how many compounding factors behind that.
But I think you just a very small part of that comment, which is really important around disparities, is maternal pregnancy outcome issues. And the more and more and more we continue to learn about those outcomes, will be great to look at that data from the Medicaid perspective. And there's plenty of data in Kentucky on that if we wanted to look at it for a conversation, prior to the Medicaid data coming through as well, because most of the moms that are in a lot of the reports and things are women who receive Medicaid during pregnancy.
So what could be a good question to ask for the data for them to bring us?
I'm not really sure. I just know, especially for women that are on Medicaid, it just seems the disparity in the treatment that they receive is causes more long-term lasting issues. And so, I'm not really sure, what data to look at to get at that, but that's just a concern that I have for us to think about it. And it's, not something that we can solve today, or we'd all be billionaires, I'm sure. But just something for us to continue to sort of have out there to think about that disparity in treatment, again, particularly as it relates to people that receive Medicaid services. It just seems like that gap is continuing to widen, and it's taking longer and longer for people to actually get to what the real issue is, because they're so sort of pushed off and not even really heard. And I don't know how, how Medicaid can regulate that, but if there is some type of way to look at that and make sure that it's at least being addressed or thought about.
Are any of the current TACs focused on maternal health?
And mine was, and mine much broader than just maternal health, but I hear why, understand why the narrowing of that.
But I mean, the reason I asked that specifically too was, that is definitely one area that we know that
it has a great impact.
that people of color have far worse outcomes during both I think infant mortality and maternal mortality during childbirth currently. And I think I could be wrong, but I think it's one of the areas that's actually been worsening, over the past few years, which is like unheard of, right? Like globally, we are missing the mark.
I believe the nursing TAC evaluates this, and Dr. Terrio, who's our medical director, who had to leave the call, she could probably address this a little bit more in depth, but we are working on a dashboard, or she is, primarily to kind of evaluate these types of things. So maybe if you want some updates on that, to put it on the agenda for next meeting.
That'd be great. That would be great.
Yeah.
Yes, please.
And I think she's scheduled to do a presentation at the MAC meeting, I believe, regarding maternal health. So that could be something if you're not able to attend that, but Dr. Terrio can certainly address that at your next meeting.
Yeah, we'll put it on there.
What the status is. Hopefully it'll be complete by then, but I can't guarantee.
Okay. Okay, so I mean, that's one topic, right? That's a topic we haven't really been able to dig into, but I think that's what I'm trying to get us to talk about it, in times like this, is what other areas that, there's so many different needs. The basis for this group in general is, I mean, it's most of, everyone has different disparities in ways that we can improve their equity. So, there's so many questions to ask, but it's just figuring out which ones we can actually try to do something about. I think a lot of our, several of us are pediatricians, so the questions I always think of tend to come from a pediatric standpoint. But adults are the most of the population, so I'm trying to include them as well. I think, like Dr. Richardson said, getting the data on things like diabetes and stuff for us would be really good between the different MCOs and things like that, because that's a huge percentage of our patients in Kentucky. That's we're one of the highest states when it comes to things like diabetes or hypertension or hypolipidemia. And so look at those outcomes and ways that we could try to address it. It's not the area that I usually work in, because again, I treat kids, but maybe we could look at it from a different perspective than people have been, or just add our own input. Other issues you guys have?
I would say that we're also doing we're doing a focus study on C-sections as well. And we are evaluating the race, ethnicity component of that as well. As you may or may not know, our C-section rates are in the 30s, if not closer to 40. So we are looking at that as well.
Do know things about, like, as far as how the different MCOs, promote best feeding, whether it's covering things like pumps or, providing or getting them in touch with lactation services. That's another thing. I know that, there's huge disparity in or difference in breastfeeding rates and things like that. I don't know that
Good
it falls
point.
into this area, but again, just another thing that I do encounter.
Katrina, can you talk a little bit more about when families or people come to you about concerns? How they what are the stories? What are they saying that sort of leads up to their current situation? Because I have a lot of families that will basically say to me, I'm not going back to that subspecialist because they're racist and they took everybody in front of me because I'm brown and everybody else was white. People feeling direct discrimination in the offices. Do people report things like that, or what sort of things? do you think?
Yeah, and of course, we've heard that. We've heard that what you're referring to is that sort of really overt, but I think more than the overt is just the types of treatment that people go in and say, you know, I'm feeling this way, I'm feeling that way, and then they're not being taken seriously. We hear a lot of times that people are told to take some type of antidepressant. That's something that we've been hearing a lot. Well, you need to take an antidepressant because you really don't have this or that. And then they have to go, you know, to several different providers before they're actually diagnosed with what the real issue is. We've heard that a lot. And again, this is anecdotal. It's not like we've done a study of thousands of people, but we have connectors throughout our 8 counties that sign people up for Medicaid. And these are a lot of the stories that we're hearing is that they'll go, they finally get to the point that they will go, but then they're told, well, you're really not sick, or it's really not as bad. So just take this, again, this type of medicine, and they don't really get at the issue until it's much, much worse. And then the treatment is much more severe.
Mhm.
I mean, that's kind of the core of disparity, right? Just that all of that is what leads to differences in hemoglobin A1Cs for diabetics and differences in ages of heart attacks.
Mhm.
All of that. I mean, that's what you're talking about is so just the truth of why we're even having a TAC, that we've got to get to that and those conversations, and how do we bring those conversations up in an effective way, because we're never going to have the data on that, right? I mean, who's going to do the study? I mean, there are some, you know, like some of Vivian's work and things like that. There's some data out there, but it's so much anecdotal that we need to find a way to listen to, and how do we hear it in a way that we can make a change.
And how do we help those that are advocates like us, you know, that are not in the health profession? Because I can't really go and tell Dr. Figueroa or, you know, any of you all, I can't have an intelligent conversation to say, well, no, this person really is sick. You know, I can't convince you of that because I don't know. But what is it that we can do as advocates for your patients or for whomever, and to tell them, well, these are the things you need to go back and do and say, so that they can get a better result quicker. And maybe that's an approach we need to think about as the TAC, to say, you know, how can we help those that are advocates be more informed? So when the families that we're serving have these issues, we know how to better prepare them to get what they need, which is the right care.
Mhm.
Yeah, I mean, that's a great point. If nothing else, we should be able to do that, right? Like that should be our minimum standard. Like we've got to have the answers for the helpers.
Mhm.
Yeah.
And, you know, and on the Medicaid side too, to say more than just, well, if you feel like you weren't treated, respectfully call this line. You know, what is something that we can recommend on the Medicaid side to make sure that these issues, when they do come up, are handled in a more that are handled in a way that those providers are going to feel it if they continue to have sort of these discriminatory practices. So Medicaid is holding those providers accountable as well.
This is Stuart Owen with WellCare. I was thinking, so we all have grievance, like you can file a grievance, call in a grievance with exactly like that, exactly what you're talking about with your provider. And we do track that. You know, so if they're calling and actually making a grievance, putting it on record, I mean, that is something that we could track anyway.
Mhm.
Yeah, and I
And then we
think,
have
you
to,
know,
we have to investigate it, and I'm sorry, have to investigate it and, outreach the provider and, question them about it. So here's what the member said, you know.
and then, and I think then, but what is the result? What is the next step? If you, and I'm just giving this as an example, if you at WellCare has 1,000 complaints, what is Medicaid then doing with those complaints? Just like, in banking, they get a rating based upon, how they handle issues as it relates to disparities. So do the providers get some type of rating or ranking? And I don't know, if that's the answer. I'm just saying, if those complaints come in, then how are we using that information to make those systems better? And we
Yeah, I
know
mean-
you only get one complaint out of thousands.
Right.
Yeah, that's a great point. I mean, I know we have scorecards as far as looking at care gaps. I mean, it's not like the complaint where you're talking about, but we look at all your members. Like, here's your roster of members. Here are the members of not getting a mammogram, not getting colorectal screening, child wellness visits, or whatever. And we score them on that. And in some cases, we have value-based reimbursement where it's tied to that. So where are your gaps? And so obviously, if people of color are the ones that are, not getting the preventive visits, stuff like that, I mean, that's going to show up there and that's going to hit them in the wallet. I mean, that's just literally looking at all their members is not, broken down by race, but if there's a gap, we bring it up to them. We have a quality team that will outreach the provider. They meet with them regularly and say, here's all your members and here's where your gaps are.
Mm-hmm.
Somebody, I think, put in the chat about recommending to get a second opinion. Well, usually people get a second and a third. So it's not just one opinion. It's going through several different layers of providers to get to an answer.
Ellen also, or Elaine, excuse me, also asked where you can call to make a complaint. I think that may have been directed towards you, Stuart.
And I don't have that number on me right now. I will check. I mean, absolutely. We have like a member customer services line, that for sure. But honestly, we don't know if we have a separate line for grievances. How about I email that to you, Aaron?
Absolutely.
Okay.
I think it will be useful to get that information from each one of the MCOs, and thank you for WellCare for doing that. And so that information can be available whenever we're treating someone and that person have expressed that the rights or the treatment has been subpar. I know, like, for example, in our offices, one of the regulations that we have, if that everywhere we have posted, if you have a complaint about the way you were treated, about the quality of the services, et cetera, you call this number, and so that's something that we can make available.
I'll tell you, Katrina, there's no required training. There's no anything on implicit bias in healthcare that we're required to do, or racism in healthcare. It's all people do it if they're interested and they want to try to improve, but there's no state requirement, which I would love for the Kentucky Board of Medical Licensure, at least for physicians, to start to require that. But that's anyway, if you could advocate for that, I would back you up, because I can't seem to be getting any movement on that. We are required to do other trainings, and this would be a really important one. So just to let you know, we don't get trained on any of that. So it's not a surprise. We are where we are.
Yeah.
I didn't know that. Thank you for sharing. I had no idea. I just assumed you did.
I dropped my email address. Oh, I'm sorry, Dr.
No, go ahead. Sorry.
I was just going to say, I dropped my email address to any of the MCOs that can send me the complaint information. I just sent off the other information request for utilization and interpretation. So I apologize. I don't want to follow up with a second email. But then I also dropped the DMS web at ky.gov. That's also an email address that's monitored by the state, that if a member is having a hard time getting a hold of their MCO or they're not sure which way to go, they can always send an email to that email address and we can get that to the proper place as well.
Mhm.
Katrina, you had asked the question earlier, and it'll probably come up in whenever we get the information on the transportation services and things like that in the PowerPoint and look back through it. But you had asked, are the services available for things like groceries and stuff like that? Were you asking if they can call and schedule basically appointments just to go, like to get to the grocery store and things like that for activities that, you know, that are health related, but not directly to a doctor? Was that kind of what your question was?
Yeah, like, are they on the Medicaid approved list trips? Do they think about the social determinants of health, those issues around grocery store or getting help with your utilities, or, you know, are those considered approved trips?
Yeah.
That was my question.
And I would even ask, you know, for kids, like would like actually their sporting events and things like that, right? And I know that when I was, and it may still happen in like the cities, but you know, when I was in high school or middle school and we had a basketball game or something like that, right? We rode a bus. A lot of the schools around here don't take buses anymore. Either the parent drives them or the kid can't get there. So they're like, the schools don't pay for the bus to transport. So, you know, these kids can't participate in sports because they don't have personal transportation to sometimes go to the games that are an hour away. I don't know if that's, you know, a similar thing, at least in my head, for kids' health, but I don't know if Rachel, if that was something that was covered in the PowerPoint or not specifically.
Well, right now there is in the PowerPoint close to the end of it, there is a clickable link on the NEMT workbook for those entering the transportation world. So I'm looking there right now to see if there's anything specific on that. I know for the value added benefits from the MCOs, absolutely, that is going to see a friend, going to the grocery store, you know, but as far as NEMT, that might be a little bit different because that is, it's all things Medicaid and going to the doctor, things of that nature, but I want to confirm. So if I find that throughout that workbook, then if I can't, then I'll reach out to Office of Transportation and make sure we give you a definitive answer for NEMT.
Yeah, and that was a value added benefit for like one of the MCOs, right? Not for
all of them, right? So the ones that currently offer the value added benefit, let's see. So like the $50 gas card, bus pass, or Uber card, that can be used at their leisure for whatever event or activity they want to use it to have transportation to. And that's provided by Anthem and Passport. So WellCare does referrals for NEMT, and Aetna is the one, again, and that was one of the top ones in the 27 counties, that they have specific value added benefits. That's for going to job interviews, the grocery store, community health services. So it just depends on that MCO's particular value added benefits and what they provide for their member.
Yeah. Any other topics, questions, new thoughts from that?
Hey, this is Susan Vickers. I'm the Director of Quality for Aetna, Better Health of Kentucky, and I just wanted to follow up. Yes, we provided all that information on transportation, but I do feel that there are many other gift card incentives that we offer that our members do use for gas or transportation. So I think, you know, holistically, there may be some more benefits that members are utilizing not specifically through a transportation vendor, but through incentives. We're able to track utilization, we're able to track the type of expense or type of need that our members use their gift cards for. And we do see a high amount of gas money or service station spending through the gift card. So I think sometimes it's hard to express that with one answer to one question, the holistic view of sometimes what the gift cards are used for. So I just wanted to clarify that in addition, to what was reported earlier.
Thank you. Okay, it's like 3. Do we feel like there's any recommendations we would like to make to the MAC at this point? I know that we've, we talked about interpreter coverage and things like that. I think we'd want a bit more info specifically, at least I feel I would, to comfortably talk about specifically what we're asking for. I know you said you want like a direct line of access for the interpreters. I don't know if that's a thing I can recommend that we have or not, or if that's just something that MCOs could just provide. So, but other than that, I didn't hear anything specifically. Okay. Next MAX meeting on the 27th. Dr. Fergara, would you like to attend that one, or we can talk about it after and kind of discuss things? I can email you and get your number and we'll figure out who will attend things and stuff.
Yes.
TAC meeting is going to be in September. So we got a couple months until I see you guys again. A lot of hot days in between. If everyone's all good, I'll wait for someone to motion to adjourn.
Well, just to throw in that clarification for NEMT eligibility, it does the individual, in order to be eligible, it has to be for a Medicaid covered service, and it has to be of medical necessity. So it's not going to be to go to the grocery store. It's going to be to go to the doctor's office, to go to the pharmacy to get medicine. It's going to be all medical related for NEMT specifically. So just to clarify.
Yeah. Thank you.
Thank you.
I'll make the motion to adjourn.
Okay. Second.
Thanks, guys.
Thank you. Voted
Thank
yes.
you very much.
Yeah. All
Thank
right.
you.
Thank you.
Thank you.